Yeah, I'm ready. Good evening, esteemed delegates, respected national and international faculty. It is my privilege to welcome you all to the Col-connect International Speaker Program on the topic Evidence to Practice Upadacitinib in Inflammatory Bowel Disease. This is a platform designed to exchange the knowledge. I am Dr. Pradeep Gore from Medical Affairs team of Torrent Pharmaceuticals. Torrent Pharmaceuticals has always been at forefront of scientific development and dissemination of knowledge. The Call Connect program embodies this mission. This program brings the experts together to share insights and experiences in inflammatory bowel disease. To explore more on this topic, we are honored to have with us Professor Silvio Denis, our distinguished international faculty for this evening. We are also privileged to welcome Dr. B.S. Ramakrishna sir, a renowned expert in gastroenterology, who would be the national speaker for today's program. Can we have sir's introduction slide? Yeah. Dr. B.S. Ramakrishna sir is Director Senior Consultant, Institute Gastroenterology, Hepatobiliary Sciences and Transplantation Medicine at SRM Institute Medical Sciences, Chennai. His areas of interest include inflammatory bowel disease, small bowel disease, pancreatobiliary therapeutic endoscopy. He has 170 journal articles, 20 book chapters, one patent, and 5 book submissions under his name. He is a fellow National Academy of Medical Sciences, fellow Indian Academy of Sciences, fellow Indian National Science Academy, fellow American Gastroenterology Association, and past president Indian Society of Gastrology. He is also past editor-in-chief Indian Journal of Gastroenterology and editor-in-chief Gastroenterology, Hepatology, and Endoscopy Practices. Dr. Ramakrishna sir has made significant contributions in advancing clinical practice in inflammatory bowel disease. We warmly welcome sir for as a national speaker for this program, and we look forward for your guidance. Without further delay, I would request Dr. Ramakrishna sir to kindly set the context for today's evening and introduce the international faculty. Sir, over to you, sir.
Can, yeah, all right. So may I share my presentation? Hello? Yeah,
Yes, sir.
may I share my presentation here?
Yes, sir.
Uh, Good evening, everyone, and thank you, Dr. Gauri, for the kind introduction. So I was asked to talk about current challenges in managing IBD patients in India as to set the context. Okay. So if we look at the data, there may be about 500,000 to 1,000,000 affected individuals in India. These two are recent articles. So here's a meta-analysis, if you like, in intestinal research this year, which shows the prevalence rate per 100,000 population of IBD in India. I actually doubt these figures because it shows the Indian rate below the Asian rate, whereas multiple publications have shown that Indians seem to be affected much more often with IBD than many other Asians, be that as it may. So here's another, this is the initial data from the Crohn's and Colitis Foundation of India registry some years ago, showing that ulcerative colitis predominates in North India, whereas Crohn's disease predominates in South India. So the challenges to IBD management in India, one is that there is a lack of awareness and there is a delay in diagnosis. We showed many years ago that the median delay in diagnosis is a few years for both Crohn's and ulcerative colitis. The second challenge is that there's an expected rise in the number of IBD patients in India. The third is that there's a change in phenotype from benign to more aggressive phenotypes. I mean, when we started, when I started clinical practice, ulcerative colitis was a relatively easy to control disease. Even now it remains relatively easy to control, but we're seeing more aggressive forms. And the same is true for Crohn's disease. Now, the next challenge is the cost of medication. So you know that lot of the medication is under patent, and it tends to be extremely expensive. And the fifth is really the lack of availability of medication to all segments of the population. And this is, in fact, the theme for this year's World IBD Day. And IBD should not have borders, it should be available, that whatever facilities are there should be available to everyone. This is a recent analysis, kind of costing of how much it costs for IBD care in India. So if you look at patients in tier 1 cities with an annual per capita income of here, it's 5.7 lakhs, which is 5,600 euros. And the annual cost, the mean cost burden for IBD is about 51.9% in a tier 1 city. These are presumably more affluent people, so more people using biologics. Tier 2 and 3 cities, where the annual per capita income euros wise is 4,200, and their mean expense on IBD care is 1,500 euros, which translates to about 36% of their annual income. So it's a heavy cost for people with IBD. The other major challenge that we see is that there are treatment failures over time. And you know, we may start with conventional treatment, but sometimes many people do well, but some people have treatment failures, and then they are treated with advanced therapies, and with advanced therapies as well, quite a significant number of them may fail. TNF inhibitors are added, and primary non-response is there for most TNF inhibitors. In clinical trials, only about 60 or 70% actually have clinical response or clinical remission. In clinical series, of course, the response is higher, maybe to the tune of 80 to 90%. And if they've been on treatment for some time, they may have a secondary loss of response. And this happens in maybe a quarter to a half of patients. And about 2/3 of patients with inflammatory bowel disease have impaired quality of life. So these then are the major challenges that we have in clinical practice in IBD in India. And with that, I'll stop.
Thank you, sir.
Dr. Anusha, can you share the introduction slide of Professor Silvio? Right. Ramakrishna sir, can I request you to
Yes,
introduce?
so can we hear? All right, thank you. That's good. So it gives me great pleasure to introduce Professor Silvio Denise from Milan, Italy. So he's professor of gastroenterology at the San Rafael University and is director of gastroenterology and endoscopy in their hospital in Milan. His research interest has been in investigating the pathogenesis of inflammatory bowel disease. He's participated in a number of international clinical trials. He speaks at a number of fora on clinical trials in IBD. He has more than 700 publications. He has a new drug patent for a drug, and he has been in the past the president of the European Crohn's and Colitis Organization, which all of you know as ECHO. He's had multiple editorial roles, and so it's a great pleasure to welcome Dr. Denise and to ask him to give his talk. Dr. Denise.
Thank you, and good afternoon to everybody. As soon as I'm able to share my slides, I will start telling you that I'm very happy to be with you this afternoon, and hopefully in the future I will be in person because I love India. And this is a little bit a comprehensive overview from evidence to practice of upadacitinib in inflammatory bowel disease. And this is a drug that has changed the life of many patients in our practice and in my clinical experience. So I will try to give you a small overview about, first of all, the signaling activities and the selectivity of UPA, trying to give you also an overview about the evolving role of UPA in IBD, also in relation to the contemporary guidelines. I will also try to compare UPA with everything that is in the field, particularly with other drugs and with the other class of biologics, and then discuss the safety, the adverse event, and the management, and also look at real-world success story for UPA in inflammatory bowel disease. So you know that we have a lot of patients with IBD. This is increasing everywhere in the world, and also India is contributing with a huge percentage of the incidents where things are changing everywhere, and also in your country. I would say that we see overall globally over around 5 million of patients. And when we think about targets, we need to think about how goals are evolving for short-term, long-term endoscopy and also histology. We will see very soon the guidelines of the STRIDE 3 initiative that is going to be released in the short term. We will see the publication of STRIDE 3 with all the major endpoints that we like to observe in our patients with IBD. Now, we have done a lot of progress. When you look at the huge progress that we have achieved from the first drug infliximab up to UPA, I would say that this has led to a major advancement in the field. And of course, UPA is the only JAK that is approved for both Crohn's disease and ulcerative colitis. And this is quite interesting because TOFA does not succeed in the early phases for Crohn's disease. So let's look at one aspect. This is the minor one, is on the role of UPA and its selectivity. That is a major aspect for also for the safety and for the positioning of UPA. You know that JAKs works in pair with several JAKs, 3 JAKs and 1 TYK2, and the JAK1 is probably one of the key driver for pro-inflammatory cytokine production. You know that JAK2 has mainly a hematological role, and in fact is approved as selective inhibition in selective areas, in selective diseases. And JAK1 selectivity gives less side effects if you think about up to pan-JAK inhibition overall. And this is quite relevant because, of course, this can lead to a easier use in practice, balancing risk-benefit ratio for our patients. And when you think about selectivity, there are multiple studies looking at how JAK1 selectivity for UPA is compared to JAK2 or JAK3. And this gives also a convenient once-a-day treatment option for our patients. You know that the doses are 45 for Crohn's and ulcerative colitis, with doses in the maintenance of 15 or up to 30 for refractory or more severe disease. Crohn's disease induction leads to 12 weeks. UC is only for 8 weeks, but you know sometimes in practice we use flexibility to extend our induction, particularly in relation to how the patient is doing and also in relation to how the patient has a history of previous monoclonal exposure. And UPA leads to pan or several cytokine inhibition that are related in inflammation by working on these JAKs that are crucial for pro-inflammation. Now let's go back to the clinic, which is probably what we interest more, and let's look at the guidelines and the key landmark trials that we have. These are the AGA guideline for moderate to severe ulcerative colitis. Yeah, of course, when you look at the efficacy, is considered one of the higher efficacy medication. You see that this is one of the most effective treatment that we have in advanced treatment naive, and in Crohn's disease also clearly as a higher efficacy medication, but particularly also for patients with prior exposure to advanced therapies. We know that this is also variable depending in Europe, but we are pretty much on the same line when you think about the efficacy. Looking green, it's always, and this is coming from direct comparison, UPA, it's always ranked higher, and intermediate efficacy, there is tofacitinib. So this means that tofa for ulcerative colitis is ranked to be lower in the JAK class, and this is another very important aspect. So these are the major aspects of the clinical trial development. You achieve and you accomplish, in which induction was done for 45 milligram once a day versus placebo, and maintenance with the UHI program, 15 milligrams or 50 milligram of placebo, and then long-term extension in the long term up to week 288. Now, when you look at ulcerative colitis, I mean, the efficacy is overwhelming. You see that no matter the way you look, for stool frequency, rectal bleeding, abdominal pain, bowel urgency, a patient is relieving the symptoms after 1 day or after 3 days for abdominal pains. This means that a patient is really experiencing in a faster manner. One of the worst things is a patient that is calling you after you have decided to start an advanced treatment and telling you, I don't feel nothing. But here, the difference starts to be obvious already after 1 or 3 days. And then these are the major endpoints. You see that both in the parallel studies, you see that you achieve and you accomplish at 8 weeks, there is high efficacy for any endpoint, for a clinical remission with nice delta, with clinical response, and these are very consistent also in the major study of the for both for the induction. And this means that while in clinical trials you measure clinical remission, in clinical practice, a patient is telling us that I feel better. I have less blood, I have less diarrhea. This is clinical response. And if you look at the number, you see that 3 patients out of 4 are improving. So this is a very high number when you think about how a patient is doing. Now let's look at endoscopic healing. You see that the bars are very high, at least 5 times higher than patients with achieving endoscopic and histologic improvement. Also in this case, the data are quite parallel and are very consistent with this very high profile of efficacy of upadacitinib as compared to placebo. And when you see the long-term maintenance, you see that the curves are very flat. This means that those patients, once it's working, they keep working, and this is irrespective of the dose, the 15 or the 30 milligram, and this is true not only for ulcerative colitis in the U-Activate program, but also in the U-Endure program in the long term. Now, looking at the capability of over time of each one of the other endpoints for clinical remission, endoscopic improvement, HEMI, steroid-free clinical remission, you see that overall, at 52 weeks in both forms of IBD, both Crohn's and UC, the data are overwhelming in favoring both doses. And that's, of course, the higher dose. It's always slightly better, as you can observe in the dark blue, but this is typical of what we see in patients that are treated with small molecule. But of course, also the 15 milligram is very effective and is quite effective also with one of the key endpoints that we use in practice, that is taking out steroids, in which you see that the majority of the patients, both in ulcerative colitis and in Crohn's disease, are able to be in clinical remission without the need of steroids. So until now, I've shown you it's a JAK1 selective, blocks multiple cytokines, it's very effective, very rapid, and for any endpoint, it works very well. Now, the key question is, how do we position? How does this compare with the other biologics or with the other advanced treatment? This is one of the major aspects that we should take into consideration. Of course, indirect comparison is quite important. And you see that UPA, it's always the best ranked. For instance, in patients that have been exposed to anti-TNF, endoscopic improvement is always higher for UPA as compared to all the others, and the same holds true also for clinical remission. You see that UPA 45 is the winner for both population in both TNF naive and TNF exposed patients. And also is important when you compare infliximab with UPA. In this network meta-analysis, UPA was always better for any outcome, including clinical remission, clinical response, and endoscopic improvement. So I think that in ulcerative colitis, there are no doubts. This is the drug that we know is very, very effective. It's very fast with the oral convenience. That is another important aspect with the once a day leads to really control in disease. And also, when you look at real world, you can clearly see that it's able to reduce colectomies to maintain patients in clinical and endoscopic response over time, also in patients that are more difficult to treat, that have been previously exposed to anti-TNF. Now, what about the one of the drugs that is used more frequently, vedolizumab? How is the comparison? Well, here is an exercise that is very easy to win because you see overwhelming data for clinical remission, clinical response, and endoscopic improvement, always higher for both doses of upadacitinib. When compared, you see that the bar are almost double for UPA as compared to the others. So this is pooled data from matching adjusted direct comparison, and also in this network meta-analysis, you see that it's always performing much better when compared to vedolizumab. So I think we are very, very convinced about this data, which is exactly what we experience in our clinical practice. So what about patients that at 8 weeks have failed biologics? You see that this is working in both population, but of course, in the delta, you see that are quite different because the biologic failure are always a little bit more difficult to treat. The bars are lower, but you see clearly that it works very well in both Crohn's disease and ulcerative colitis in an easy manner, particularly for patients that have received already biologics. And of course, when you look at the type of biologic and the number of biologic, the efficacy lowers a little bit. In Crohn's disease is very clear. This is the story of Crohn's, but also with ulcerative colitis. And you see that irrespective of the type of previous treatment, upadacitinib can be used always, but if you use with less treatment experienced patients, those patients are the ones in which upadacitinib will be more effective. What about biomarkers? You see that also biomarkers are doing much better, not only for CRP, but also for fetal calpro. These are very consistent, and both doses in the maintenance are able to achieve the same clinical effect. So this is also important for the stride, for the treatment guidelines that I was mentioning. What about in the class? Now, I showed you so far that also, irrespective of the treatment, UPA works for any type of patients. It works better if the patients are naive, but if we need to select a JAK, why should we select UPA as compared to TOFA? Well, I told you already from the guidelines, the positioning. I told you already from the JAK selective 1 inhibition. But if you think about TOFA in particular, you see that These are the pooled data from matching adjusting direct comparison. And once again, you see that UPA is always better in terms of endoscopic improvement and clinical remission as compared to TOFA at 1 year. So I think that both doses are much better. You see that both 15 and 30 milligram are acting in a better manner as compared to tofacitinib. And this is also true for the steroid free and for the speed. You see that after 8 weeks, basically, steroid free of UPA is always higher, of at least 10 points as compared to TOFA. So there are always better possibilities of UPA to win steroids as compared to tofacitinib. And what about refractory case or of TOFA? Can we still use after TOFA UPA? Yes, it's possible. And you see that these patients still will have a clinical benefit. 1/3 will achieve clinical remission, and 1/3 will be in steroid-free clinical remission. So this is quite relevant because also those patients previously exposed to another drug, because UPA is perceived to be much more effective. You see that in this failing patient population previously exposed, still there is a benefit of using upadacitinib even after tofacitinib. Probably those patients, when in this case series it was not yet approved, because otherwise they would have used upadacitinib as first line. What about safety? This is one of the most important aspects. I would say that safety, when you look at overall adverse events with the risk of VT, MACE, zoster, I think that zoster is the only thing that is slightly relevant. That's why we need to vaccinate our patients. But overall, the safety profile is very consistent with what we have, I think, with an anti-TNF for serious infections and so on. So I think there is no need to be worried. The only real worry is to have a patient that is undertreated. This is something that should not happen in 2026. And in fact, when you look at clinical safety overall, these are pooled data, once again, from matching adjusting direct comparison with TOFA, you see that less serious adverse event overall as compared to TOFA, but this is due to the fact that these are patients with UPA treated that are in a deeper control of systemic inflammation. So what about the patient support? How should we do during ongoing IBD therapies? Well, this is all in the prescribing information. Be careful to renal impairment, hepatic impairment in the elderly. Breastfeeding, do not breastfeed. Contraception, and then stop the dose before thinking about that. In pediatric, safety is not well established. Just screening is I think screening is nothing more except assessing for risk of thrombosis, and then nothing else in the monitoring except the lipid profile, serum creatinine, and then all the rest is pretty much the same. One important thing is vaccinate your patient for zoster just to reduce the potential risk. What about real world? Are there cases that we can share? Yes, I would like to share with you this Italian case. This is a young patient, 27-year-old, no family history of IBD, extensive ulcerative colitis. This patient is classically active with several bowel movements per day. He has blood in the stools, mild abdominal pain, urgency. And these are the previous treatment. This patient has already received infliximab, tofa, vedo, Ustec, everything. So it's one of those patients that we define multi-drug resistant with high fecal calpro. You see that colonoscopy shows clear inflammation, including several activity at bowel ultrasound, as depicted here. Patient starts UPA, you see a strong reduction of all symptoms, of all the endoscopic, probably you will see later on with fecal calpro going to normalization, and this is the endoscopy. You see beautiful endoscopic killing with bowel thickening normalization. at the assessment that was done with ultrasound. So in this case, it's just to show you the potency of this drug that probably if we would have used as first line, these patients will have not undergone all those treatment and previous exposure. Let's look at second case. This is a case of a patient with symptoms that are once again typical of a Crohn's patients. This is a 36-year-old ileocolonic Crohn's since 1995, not operated, urgency, Harvey brush of 9, joint pain, and this patient once again has this very long history of previous treatment. You see that patient is quite active with anti-TNF history, secukinumab and so on. And this patient starts with very active disease, SSD of 27. It's quite heavy in terms of clinical activity. And when you see what is happening to these patients after the start, you see that there is improvement over time with fecal calprotectin that goes to 238, and then reduction at ultrasound of the bowel thickening and of the bowel activity as assessed by power Doppler. And this is once again the success of this patient from 27 to complete endoscopic healing. So I think that this is quite relevant and is another very nice example on the potency of this drug. And once again, I always wonder why should we wait as last resort whether we have a very effective drug and just stop inflammation once forever. So this is the overall comparison. When you think about the class, the formulation, immunogenicity, remission, and endoscopy of UPA as compared to TOFA and the other biologics, I mean, when you look, it's always the best, and this is very clear to be one of the best drugs that we have in our clinical armamentarium for both ulcerative colitis and Crohn's disease. So this leads to my summary. UPA is a highly selective oral JAK inhibitor that is redefining the treatment landscape in IBD, robust efficacy and safety with efficacy in both treatment naive and experienced, very high bars for a steroid-free remission, low cardiovascular and malignancy rate leads to a profound use we are using with happiness in our clinical practice. And I think that this is a drug that will be used more, also in combination with the field evolving towards combination. Thank you very much for your attention and happy to take any question.
Thank you so much, sir. That was excellent deliberation, and that was covering all the aspects from clinical trials to real world experience also. The question answers we will be taking after the BSR sir's presentation. That is a dedicated slot for question and answer. We will be taking question answer at that time, sir. If okay with you, I request you to kindly stay with us, sir. I would now request Dr. B.S. Ramakrishna sir to kindly take us through his presentation on the topic Indian aspects in IBD care and case presentations. Sir, over to you.
Thank you. So basically, I'm going to share a couple of case histories of IBD patients that I have. These are real life case histories of patients that I've treated with upadacitinib. So the first patient that I'll present here is a 19-year-old undergraduate student who, at the age of 2 months, had a left nephrectomy. She had a horseshoe kidney. The left side had an infection at the age of 2 months that was removed. At the age of 11, she was diagnosed with Turner syndrome. In 2021, which is 5 years ago, she developed diarrhea and she was investigated. She was positive for anti-TTG antibody. The upper GI endoscopy was normal. And she had a biopsy which was reported as being consistent with celiac disease. And this all happened elsewhere. So at the same time, she had a colonoscopy which was reported to show pancolitis with deep ulcers. And the colonic biopsies, the report said that there was crypt architectural distortion, crypt abscesses, and ulceration. Now, this young lady at that time, she was started on mesalamine. And for a period of about 4 years, she was doing relatively well. In 2025, she had a recurrence of diarrhea. Her stool frequency increased, and the fecal calprotectin was greater than 800. At that point of time, her hemoglobin was 10.4, her white cell count was normal, platelets were 350,000, albumin was normal, and she had an iron deficiency. Colonoscopy showed loss of vascular pattern, friability, superficial ulcers, and mucopus in the lumen. And biopsies from the ascending colon, transverse colon, descending colon, sigmoid, and rectum all showed moderate chronic active inflammation, so fitting the diagnosis of ulcerative colitis. And essentially here, this is what it looked like. So at this point of time, this is the time that actually at that time that she had relocated from her hometown and come to Chennai to study here. And that is the point of time at which I had seen her, and she was actually referred to CB. And with her mother, who was in the who works in the pharmaceutical industry, I discussed the options of conventional treatment versus biologics versus JAK inhibitors. Because that was the time actually that JAK inhibitors had become available in India. This is Jan 2026, beginning of this year. So initially the mother said, let's go with conventional treatment, I cannot afford biologics. So she was started on prednisolone and azathioprine at a very low dose. But a month later, she came to see me saying stool frequency had increased and there was blood with each stool. And evaluation, again at that time, for pathogens didn't show anything. So at that point of time, we considered starting her on JAK inhibitors because biologics were not an option for her financially. So the trouble was that she never had chickenpox and she had not been vaccinated for chickenpox. If I had to give her chickenpox vaccine, which is a live vaccine, I'd have had to wait 2 months because to give the first dose and then the second dose and wait another month before starting JAK inhibitor. So I cautioned the mother, said that if she gets in contact with someone with chickenpox, that she might have a very severe reaction. But the mother said, that's all right, let's go ahead with this. So we gave her Shingrix vaccine. And in February, I started her on upadacitinib, 45 milligrams a day. So this we continued upadacitinib till June. So this is actually 4 months at 45 milligrams. When I saw her in June, that early this month, the stool frequency is down to 2 a day with formed stool. So I have reduced the upadacitinib dose and administered the second dose of Shingrix vaccine. So the learning points from this, so if we look at the timeline here, 2007 she was born, she had a left kidney resected, at age 11 Turner's, at age 14 diarrhea with a diagnosis of celiac disease and ulcerative colitis. Between 21 to 25 she was relatively well on mesalamine. In 26, at age 19 when she came to college here in Chennai, diarrhea was worse. We stopped the mesalamine, put her on steroids and azathioprine. And a month later, there was bloody diarrhea again, so started upadacitinib. And 4 months later, she remains well. So the learning points from this, one of course, is that Turner's syndrome predisposes to both IBD and to celiac disease. And here's a young lady who has both, apparently. She initially responded to mesalamine, but later exacerbation without any identifiable factors for non-response. So one of the things that we should remember sometimes is that some people, for whatever reason, they become sensitive to misalamin. And so occasionally we see patients whose diarrhea worsens after taking misalamin. And so presumably that's what happened to her, and that was one reason for stopping that. And when she had this relapse, there was no response to prednisolone. Importantly, this young lady, we started her on upadacitinib, although she never received advanced therapy in the past. Under these circumstances, and particularly somebody who's never had chickenpox, who's not been vaccinated, I think it's important to discuss with the patient and family and have them on the same page. She's responded well, I'm happy to say, but the long-term outlook is still awaited. So next, I will present a person with Crohn's disease who was started on upadacitinib. And person was actually started on upadacitinib 2 years ago, much before it was available in India. So this is a young man this is a gentleman who was a government official in a neighboring country. In 2011, he had an ileal perforation and underwent a right hemicolectomy. And strangely enough, he was not started on any treatment after that. Perhaps they thought it was tuberculosis. 2014, he was investigated and started on misalamin, which in retrospect probably was inappropriate. In 2016, he went to Bangkok and consulted there. A diagnosis of ileal Crohn's disease was made. Misalamin was continued, but he was started on budesonide and azathioprine. And a few months later, in 2017, he came to SIMS to see me. So 2017 was his first visit to SIMS. Colonoscopy showed an iliotransverse anastomosis with 2 strictures in the ileum, and there were some ulcers in the ileum. The biopsies showed granulomas. So what I did was in 2017, we had few choices, increased azathioprine to 100 milligrams a day and put him on Pentasa, which I believe is helpful in small bowel disease, so at 2 grams per day. In between 2017 to 2021, he was just corresponding with me by mail, and in 2021 he came back for a follow-up. Again, colonoscopy showed granulomas in the ileum. His fecal calprotectin, interestingly, was not high. It was only 30. Because he was symptomatic, I advised adalimumab, which would be available in this country, but he was not willing. He increased the azathioprine to 125 milligram per day and increased the pentazide to 4 grams a day. A few months later, he wrote to me. He was getting his blood counts checked regularly and corresponding, and he had developed leukopenia, at which point I told him to stop the azathioprine. He came back in 2024. The colonoscopy showed an anastomotic ulcer, and there was chronic active inflammation, by which we mean there was cryptitis and crypt abscesses consistent with active IBD. At this point of time, we considered biologics versus JAK inhibitors. He had a history of chickenpox in childhood. He had in fact had herpes zoster 20 years ago. He had been completely vaccinated, including hepatitis B, A, COVID vaccine, pneumococcal vaccine, and influenza vaccines. So in March 2024, I started him on upadacitinib. And this was because upadacitinib was available in this country. It was available as 15 milligram tablets. So he started on 3 tablets per day. In July 24, because at that time the prevailing wisdom was, after 3 months, you reduce from 45 to 15 milligrams a day. So 3 months later, when he was corresponding with me every month, and so I asked him to reduce the upadacitinib to 15 milligrams a day after 3 months. He started developing occasional loose stools, mild anemia. Fecal calprotectin continued to be low, at that point, I said just increase the upadacitinib to 30 milligrams a day. So it's just empirical kind of treatment. So he has actually done well on that, except that this year in April he had herpes zoster again. So if you remember, he had herpes zoster many years ago, 20 years ago, but he's again had herpes zoster. So at that point of time, I said stop upadacitinib. He was given valaciclovir, waited for 2 weeks, and restarted upadacitinib. And then we gave him Shingrix vaccine, and he's currently doing well. So this was the timeline in him. 2011, ileal perforation, right hemicolectomy. 2016, Crohn's disease diagnosed, azathioprine and budesonide. 2017, endoscopy showed strictures, granulomas, so he had B2 disease. Azathioprine was increased. 21, follow-up, granulomas persisted, refused biologics. 22, he had an adverse event with leukopenia. Azathioprine was stopped. 24, a JAK inhibitor, upadacitinib, was started at 45 and then dropped down to 15 after 3 months. Subsequently, I had to increase the maintenance dose to 30 milligrams a day. 26, he had infection, herpes zoster, Shingrix vaccine. And right now, the outcome is that he's clinical remission. So the learning points from this are one, that this gentleman had post-op ileal Crohn's disease, which is Montreal A3L1D3 here. Histological granulomas supported the diagnosis. He had thiopurine therapy for 5 years, then discontinued due to leukopenia. And for the last 2 years, he's had an excellent biochemical and clinical response to upadacitinib. He's had herpes zoster during JAK inhibitor treatment in spite of a past history of herpes zoster. And that is something to keep in mind, that just because he's had it before, that doesn't mean they're not going to have it again. And in fact, the recommendation is that even if they have herpes zoster, you should give Shingrix vaccine, and that is enabling continued therapy. And it looks like the maintenance dose is possibly higher for B2 and B3 disease, and that's what I found in this gentleman. And with that, I'll stop. Thank you.
So thank you so much for your presentation and sharing the clear real-world clinical experiences with all the delegates, sir. Thank you so much. Thanks again. With this, we move on to question and answer session. We have a couple of questions already in the link. So the first question that is appearing for today's evening is in suppose in case of a mesalamine or steroid failure patient, particularly which subset of patients are ideal to initiate the upadacitinib?
Can you repeat, please?
Yeah, supposedly the patient is having mesalamine and corticosteroid failure. Now it is decided to move on to advanced therapy. So, which particular group of patients would be ideal for upadacitinib?
A steroid refractory patient for sure, no doubts. But also
Yes,
for
sir.
the steroid dependency, I would say that you can use without any problem. So this is something for both Crohn's and ulcerative colitis.
Right, sir. Uh, any particular characteristics of patient would be best suited for upadacitinib, sir?
I would say that except patients that have contraindication, previous history of thrombosis and so on, I think that there is no issue at
Okay.
all.
Sir. Ramakrishna, sir, your views on this best suited patient profile for upadacitinib after mesalamine and steroid failures?
Yes, so I think we're getting to a point where, so firstly, maybe a year or two ago, we would have considered biologics first. But I think at some point of time that, as our experience with upadacitinib increases, we might well progress to a point where we use it right away for somebody with steroid dependence or steroid resistance.
Right. Sir, next question for today's evening would be, suppose in patients with pre-existing tuberculosis or a pre-existing herpes zoster infection or any hepatitis B virus infection, what should be the approach? Should we start the upadacitinib and or should we treat both the conditions together, sir?
So generally what we do, we ask
Yes, sir.
infectious advice specialist because we are not as good as our Indian colleagues for that for sure. And we will pre-treat with the antiviral or the anti-TB, and then eventually we can use. Of course, this is variable depending on the other option of the patient, but if is needed, there is no contraindication, no issue for that.
Right, sir. Sir, can Ramakrishna sir, can you add Indian context, sir? Because TB is quite prevalent
I,
in India. Yes,
I,
sir.
would- I certainly agree with Dr. Anis. Basically, I guess we would treat the infection first before we go on. But there may be occasional patients
Okay.
where you might think about it simultaneously. It all depends on context. But by and large, treat the infection first and then go ahead.
Then the Crohn's disease.
Yes.
Right, right. Sir, while choosing between the different JAK inhibitors, for example, tofacitinib and upadacitinib, how do you rate the safety profile of upadacitinib and tofacitinib? We have seen the clinical trials we have seen, but what is your real world experience for safety, comparing the safety profile of upadacitinib and tofacitinib?
Excellent, particularly with Tupa, depending on the dose, and but overall, I would say that both JAKs we should not be scared.
Sir, your view, sir?
Yeah, so I am somewhat colored by my initial experience with tofacitinib. So when I had problems in terms of resistant infections or persistent infection and non-response, and to me it seems that upadacitinib is a safer drug, but that's, as I said, that's a personal anecdotal experience rather than anything that is rooted in evidence.
Right, sir. Right, sir. Thank you, sir, putting up this in apt way. Sir, to initiate the advanced therapy in inflammatory bowel disease patients, guidelines recommend multiple prerequisites. And sir, considering Indian context, multiple like resource poor setting, etc. What are the mandatory prerequisites that should be satisfied for starting the UPADA? Sir, I would request you to take this question.
Are you talking to Dr. Danis or to me?
Sir,
To you,
to you, sir.
for sure.
Yes, sir.
Right. Okay.
I'm
All right.
sorry.
Yeah. So there are some prerequisites. I think I would in a child I would still approach upadacitinib or JAK inhibitors very cautiously. I would still prefer biologics. So at least until I develop more experience with the drug. Second, in women of reproductive age, and particularly those who are going to start families, I would be very hesitant to start upadacitinib or a JAK inhibitor. In patients with other kind of immune problems, particularly if they've had tuberculosis. So again, I think I would be a little cautious in starting this. Doesn't mean that I won't start this. It's just a matter of acquiring more experience over a period of time, and that's actually how clinical practice evolves. So first you start it in the ones that are least likely to have problems, and then you progress as we go on. And then if you look at biologic behavior of disease, uh, so in terms of perforating disease in Crohn's disease, so I think probably upadacitinib I would use. I do not know about stenotic disease, how much it helps. And we can look to Dr. Danis for guidance here because I'm sure his experience is better here.
Yeah, I agree with you. No more than that. I fully agree with you.
Right, sir. Right, sir. Sir, one question is regarding the switching between the advanced biological therapies and putting the patient to JAK inhibitors. So, can patient be switched from biologicals to upadacitinib, and what are the key practical consideration to keep in mind when this switching is to be done? And certain questions related to what should be the dose and what should be the ideal duration.
I think
Professor
that,
Silvio, can I have
yeah,
your views on
I
switching?
think you can start right away without waiting. This is not a major issue. You don't need to wait because we even use in combination sometimes. And what is the right dose? It will the dose for induction is always the same. Most of the time, if the patient is not brought into remission, the important thing is if you continue with 30 and a patient has still good symptoms, resolution, but for instance, some calc protecting activity and so on, don't go to 15 milligram because those patients are going to flare. So there are a lot of doctors that
Okay.
use lower dose, don't do that.
Yeah.
Ramakrishna, sir,
So,
your
so,
views, please
so
share.
I agree. In fact, so I have in the last few months, there are several patients that I've shifted from biologics to paracetamol, and that's because it is because of the cost that's involved. And the people come and they ask, how long do I have to continue this? And we used to tell them. By the problem is that sometimes patients are given the impression that biologics is something that you take for a year or two and then you can be rid of the disease. That's certainly not true. So I always tell my patients, if you go in for biologics, aim to be with them lifelong. I mean, if you're lucky, then you may get off earlier. So there are people who come back and say, now I think I've been in remission. Can I do something? And so I have changed patients from biologics to paracetamol, and at least the preliminary experience is encouraging.
And sir, your dose for induction and maintenance and how long
Well, the dose
uh,
is the same. I mean, it's 45 milligrams to start with, and then the maintenance is 30.
maintenance is 30 in those cases? And how long do you usually do keep this,
I guess
recommend to keep?
at the moment it is lifelong, right?
Right, sir.
You
Sir,
see,
supposedly,
when sulfasalazine was introduced in the
Professor,
market, we used to have a full page advertisement on the back of Gut, the journal of the British Society of Gastroenterology, Gut. So it says sulfasalazine, it used to say salizopyrin ad infinitum. All right. So ad infinitum means you never
infinite.
stop. And that's I mean, to me that's what IBD treatment is.
Right, sir. Right, sir. Thank you so much for clarification on the dosage as well as the duration of upadacitinib. Sir, on the similar lines, there are few questions related to switch between the TOFA also. So biologicals, we are clear. Switch between the TOFA, how it is done, whether it should be done, what dose and what duration. I guess the
I will
same
not
thing.
switch a patient that is in remission with one or the other. But of course, if you have
Okay.
patients losing response with TOFA, you can easily switch and use the second one.
Right, right, sir. Right, sir. Ramakrishna, sir, would you recommend, sir?
Yeah, so I agree. I mean, if somebody is responding to tofa, I wouldn't switch. But now I tend to, even in ulcerative colitis, now I prefer to start upadacitinib rather than tofacitinib.
Right, sir. And sir, for the real world experiences in Indian context that we getting, the tofacitinib is positioned in uh, ulcerative colitis, and upadacitinib is being positioned in the Crohn's disease. So, can upadacitinib be considered as the first choice JAK inhibitor in both ulcerative colitis and Crohn's disease, both the conditions? Uh, Professor Servio, your views?
Honestly, as I said during my talk, a drug that has both indication has the perception of being a more effective drug.
Right, sir. Ramakrishna sir, your
Yeah,
views?
yeah. So yes, it can certainly be used in both ulcerative colitis and Crohn's. And in fact, in the
Right, sir.
past, before
Ra-
Upadacitinib was available in India, when in some of my patients who weren't responding to anything and couldn't afford biologics, I have used tofacitinib off-label even in Crohn's disease. But
Okay. Okay. Sir, once the maintenance is done and the clinical remission is achieved, endoscopic improvement is achieved, then some extent histological improvement is achieved. Sir, do you recommend to add steroids and mesalamine along with the upadacitinib therapy? And if yes, to which particular group of the patient do you recommend to add, sir?
You mean steroids with UPA?
Yes, sir, steroids or mesalamine with UPA.
No,
If
ideally,
yes,
the important thing
particular
is
group.
that is to remember that patients have to go endoscopy and very soon also histological remission. If the patient are not in that condition, we can do anything else to justify that, but not with steroid generally.
Right, sir. Ramakrishna sir, can I have your
yeah,
views on this, sir?
if they're in remission, why would we add steroids to Upadacitinib? It's for induction, yes, but why for someone in
Mhm.
remission? I don't. There's no rationale to that.
Got it, sir. Right, sir. Right, sir. Sir, there are some questions related to usage of upadacitinib with regards to patients who are CVD and MACE and elderly population or CVD. In those patients, how do you proceed with upada? That question.
I didn't understand what type of patient. I read that there is a request on
Sir,
primary failure to infliximab and
multiple
fistulizing
multiple.
perianal. With perianal, yes, there were around 37 patients with fistula that did well with fistula closure. So yes, absolutely, this could be an option that is very valid.
Fistula in bronze. And sir, how do you proceed to upadacitinib in elderly patients with multiple comorbidities like CVD, CKD, or patients who's having extra intestinal manifestations?
So the first rule of medicine is not nocere. So it's possible to use, but it will depend on the risk benefit profile of that patient. So it's very difficult to answer to this broad question if we don't see really the patient and if we discuss with the patient in terms of risk benefit what is the most effective option that the patient will have.
Ramakrishna sir, your
Yeah,
views?
absolutely. I mean, there's no way we're going to do that without. It should be a very individual decision.
Right, sir. Right, sir. So, then how long we have covered? Words we have covered. Then there certain set of questions related to newly diagnosed IBD. Can upadacitinib be given to newly diagnosed IBD patients and how long duration, sir?
So is after generally is after treatment with at least one cycle of steroids, and then the other important thing is that depending on the label, for instance, in Europe you must fail anti-TNF, but if a patient is, for instance, acute severe steroid refractory, you can choose to use UPA.
Right, so thank you so much for your response, sir. Ramakrishna, sir.
Yes, I think so. If you're saying when will you use it first off in somebody, I think the time is yet to come. It will happen at some point of time, but right now, in somebody with mild to moderate disease, I would not. With severe, let us say acute severe colitis, possibly yes. I mean, as straight,
Okay.
otherwise, after a trial of steroids.
After trial of steroids. Point noted, sir. Thank you so much, sir. Sir, then certain questions related to practical counseling requirement to improve the outcomes to the patient.
What do you mean? I don't understand the
Counseling
question.
tips, practical. Sir, what are the practical counseling tips that should be given to improve the outcomes for the upadacitinib to the patient?
Make sure that the patient will achieve the target as we would do with any other drug. So check according to treat to target guidelines that the patient is really under control, and remember to take the medications because oral the risk of compliance is it's higher.
Sir, your views, sir. Ramakrishna, sir, your views, sir.
So always there's a dialogue with patients, and I think they need to be educated. And that's so the advantage with opedocitinib. It's just one tablet a day, compared to multiple sachets of mesalamine or multiple tablets of steroids or multiple tablets of azathioprine. So there's a bit of an advantage in that.
Okay. Sir, there are two clinical questions. Can we consider upadacitinib in IBD with piles,
What is
hemorrhoids?
piles? Hemorrhoid, yeah, why not? Yeah,
Hemorrhoids.
Infl-
no problem.
All right. No.
Hello.
Yes, green light.
Am I audible?
No, Dr. Pradeep, I think you're
Frozen.
frozen.
Yeah.
Uh, Sir, can you take that question, sir? Can we consider upadacitinib in IBD patient with pile patient and
Yes, yes, I
in
said
perianal
yes.
fistula?
Yes, yes,
Yes,
already
yes, sir.
answered.
Yes, sir.
Yes, there were a good proportion of patients that did really well.
And both pile patient and
Yeah.
perianal fistula patient also. Sir, Indian patients, any experience with Indian patient with similar conditions, hemorrhoids and perianal
So
fistula?
why the hemorrhoids doesn't really impact the thing? I mean, that's a separate issue. Clearly,
Exactly, it's not an issue.
Right, right. Sir, we will take up the last question for today's evening. What precautions do you suggest when upadacitinib is prescribed in patients who have undergone solid organ transplantation?
This is a tough one, has to be decided on a case by case assessment and checking what are the best options for those patients, honestly.
Right, right, right. Sir, Ramakrishna, sir,
I,
any
I would agree.
when
I'd
solid
still
organ trans
go. I would still agree. That's why I would agree. I'd still go with biologics in that case. But bone marrow transplant is where we see patients with IBD. In fact, bone marrow transplant per se helps the IBD in many of these patients.
okay, okay. Right, sir, right, sir. Thank you so much for sharing your clinical experience and you're solving most of the queries, sir. Let us move to closing remarks or on behalf of Torrent Pharmaceuticals and Call Connect program.
Thank you.
Sincere gratitude to all who joined us today. Our sincere thanks to Professor Silvio for sharing his invaluable experience, expertise, and perspectives in IBD management and or upadacetinib. Your insights have enriched our understanding and inspired us to translate evidence into practice medicine in inflammatory bowel disease. We are deeply grateful to Dr. B.S. Ramakrishna sir for guiding the discussion with clarity and depth and for ensuring the meaningful exchange of ideas and putting the Indian context, telling that therapy to Indian patients. Thank you, sir. Thank you for thank you delegates for taking out time and joining us. Special appreciation to Call Connect team for their dedication and seamless coordination. Thank you once again, and we eagerly look forward for continuing this journey together in future. Thank you so much,
Thank
sir.
you. Thank
Thank
you. Bye
you.
bye.
Thank
Bye
you. Bye
bye.
bye.
Dr. Anusha, you're there?
Yes, Dr. Praveen.
Yeah. So
Just
most
allow
of
me
the
a
questions
moment.
we have covered. Yeah.
Yeah, just a second.
Mhm.